So I'm introducing Dr. Hanif Nagaria. It gives me immense pleasure to introduce him. He's a great supporter of APPIC and very enthusiastic. He's a consultant neurologist in BC, trained in New York, and has further training in Parkinson's disease, deep brain stimulation, headache, Botox therapy, pain management, and sleep disorder. He's going to talk about recent advances in migraine management. Please, Dr. Nagaria.
Assalamu alaikum, everyone. After having such a great time with the Friday cruise and Saturday CMEs with all the information you've received and Saturday gala, I thought that we should change a little bit of topic and present something in the patient with migraine management, with how do we present with AI and see that this artificial intelligence, how do we implement this in our practice? As Dr. Karimuddin just said, that we as doctors, we are loaded with stress. And I'm going to say that you're all going to agree that I spend at least 1 to 2 hours after seeing my patient, most of you do, with the paperwork and charting and transcriptions, even though we have AI to dictate, but still it is not stopping. And even they have given us EMR that has increased our workload more. And that increases the internal stress with all the paperwork. So I thought that how do we improve the quality of life of physicians, the patients, our staff? So how do we structure something to develop something, which I'm working on it. And it's a little trial, see inshallah, with the time, how do we do it? I'm going to briefly present a little bit of migraine. I know that here some of the gurus are sitting here, those who are involved in the migraine medications development, but we're going to briefly talk about migraine and see how the avatar is going to improve the quality of patient with migraine headache. And this you can similarly use in your own practice, whether you are internist or whether you're cardiologist, nephrologist, stroke specialist. We can design those things that those, when you are there, the avatar can take over after you've taken the history, because the time is very important for physician, which I see that my time goes repeatedly talking on the same topic to the patient. So how the avatar can take over and discuss those things which I repeatedly talk to the patient, whether it is sleep hygiene, headaches, seizure precaution, as Dr. Mubin discussed all those things. That avatar can do the talk, and then the patient can be requested that we can make a follow-up appointment to discuss further things. So I don't have any disclosures. Basically, whatever I had received it, we have donated to APPIC. Thank you. No, we did work hard and we achieved whatever we did, and I'm very pleased that we all teamed together to do this talk and this presentation today. So anyway, as you all know, that migraine is very common in the female, 1 to 3 females versus 1, and 1 in 10 persons 1 in 10 has migraine headaches. If we look into it, that about 40 million people in the United States have got migraine. So you can see it's a very great field to be in. And when I look into the prevalence, it's 12% there. We have 12% here also, and 1 to 2% in chronic migraines. So when I see that the migraine is a leading cause of disability, does anybody know what is the first leading cause, as migraine is second? Any volunteer? It's chronic back pain. So just somebody's right there. The back pain is the one which is, and both are the neurology field. You can see that. So there was so much need of development of medications, because we were having traditional medications for acute treatment as well as for preventions. So scientists, doctors, physicians all get together to understand that how do we cope up with treating those patients and giving them the medications with a lot of side effect, and therapeutic gain was not very large. There was a lot of adverse effect when we look into it. And when we see that the contraindication in some of these medications were working on the beta receptors, causing vasoconstriction, and they were very difficult to use, or it was risky to use in patients with coronary artery diseases. So considering that in the background, you can understand that the challenge and this thing came in to develop new products with CGRP and immunoglobulins. First, we can talk a little bit about the migraines. As you know that there are different type of migraine. The migraine headaches which present with aura classically, they are called classical migraines. Without the auras, they are called common migraine. But we as scientists, neurologists, we deal with complicated migraine, retinal migraine, ophthalmic migraine just with aura, without any headache, and so on and so forth. So we deal with some very deep kind of issues which we get referral day in and day out, and I'm sure all these neurologists sitting here, they're going to agree with that. Those patients who have prodrome, they present with activations with the hypothalamus and the limbic system and with altered thalamic activity. And the patients with auras, you can see that the thalamic activity with the cortical spreading, that's the target was there with the CGRP and immunoglobulin, that how we can decrease this aura-related migraine and decrease the cortical spreading. Then patients after that is the headaches, which you all know that the activation of the TNG nucleus, the trigeminal vascular system, releases the neurotransmitter, particularly the CGRP and other glutamate and other neurotransmitters were releases. So our target was again the how we can prevent the CGRP, how we can block the CGRP. Of course, we had medications. The triptan were blocking the CGRP, but the cost was there with vasoconstriction. So the new development was to prevent the vasodilations. Migraines has different phases, as we just discussed about that. The pathophysiology here again is the hypothalamic activation of the TNC trigeminal nucleus, causing the release of the CGRP at both the arterial fiber and C fiber and A delta fiber. This CGRP activations causes vasodilations. So again, the same pathogenesis was kept in the mind when the new medications were developed. And here you can see that how this hypothalamic activations is activating the trigeminal nucleus with the C fiber. So this hypothalamic activation is activation of the TNC fiber, the C fiber activated, and the vasodilation is happening. The medications were designed to target, like the CGRPs medications, the GPANs and the immunoglobulin were targeted to designed to target the CGRP. We have the triptans which are used here at the 5-HT1, and of course the Botox here and the snare, which you can see that. This is rather complex with the pain mechanism. And again, how the pain pathways are conducted through the thalamus to the brain, and how we can conduct to stop these pathways and what medication can be used. These are the newer studies which have been done there. So migraine can be divided into migraine with auras, migraine without auras, and chronic migraine. The ICSD classifications have specific need and requirement in order to diagnose the patient as migraine with aura. So greater than 2 attacks fulfilling these B and C criteria where the patient has auras, whether it is visual, sensory, motor, or brainstem, or any of those criteria there, with those auras should be presenting there. But specifically, the patient should not have any ICSD diagnosis not better than accounted for the ICSD 3 criteria, and the TIS should be excluded in that. Migraine without aura, these are the patients who had greater than 5 attacks fulfilling the B to D criteria. They have headaches lasting for 4 to 72 hours, and classically they can present with unilateral pulsatile throbbing headache, which are aggravated with minor physical activity. So normally when we comb the hair or when we do minor activity, we don't get that much pain, but these patients, they present with severe pain, and that's the disability of the disease. Chronic migraines, they are classified the patient presenting with at least headache for 90 days, and they should have 15 days of headache per month, greater than 15 days. So that's the chronic migraine headaches. Now they have other specific criteria on that these patients, they need to have 5 attacks, fulfilling the criteria B to D for the migraine without aura, or B and C with auras. Another question which comes in with a lot of the patients and the family physician ask that, how do we approach when you are seeing the patients with migraine headache? So once you have taken the history or examined the patient, you have done the imaging study to exclude any other conditions which can present with headache, all those conditions, then we come to the history. If the patient has more than 3 to 5 headaches, they can also use the preventative medications. And the acute medications which are used, they have burdens of side effects. So patients who are taking over medications with acute triptan and they have chronic headaches, which we want to prevent the patient to go to chronic daily headache. We want to keep them in the episodic headaches here. So the idea was to see that if the patient has a lot of side effect, if they're having contraindications with coronary artery disease and other things, how do we use the preventative medication so that we don't have to reach to treat them in the acute category? So the traditional approach to the treatment with migraine is acute treatment and preventative, which all of you know because most of the family physician and other people also treat the migraine headache. The approach is generally, which is available, is non-steroidal. People are taking Tylenol, Advil, they are just like rushing like, no reason. So what our family physician colleague can do when they see the patients and how do they approach these patients? So you have to approach with a specific thing that they can be treated as preventative first and then the acute treatment can be used. For the preventative, we can use antihypertensives like beta blockers and antidepressant medication, as well as antidepressants like amitriptyline or anticonvulsant medication like topiramate. Thank you. There is an evidence-based guidelines in treatment of patients with the migraine that how do we do the prevention and what medication we use. We just say that the well-channeled topiramate and beta blockers are used in the level A, and in the level B we use the amitriptyline as well as some of the medication in level C. But the guideline for the level A was more useful and more beneficial for the patient. Of course, the recent advances of the treatment which are there and which we will discuss briefly, that these patients, they are again divided into acute and preventative treatment, and some of the medicines are overlap in the acute treatment and the prevention. As you can see, that G-pens are in both the group of acute and preventative, and recently all these neuromodulation devices are also used for the acute and for the prevention also. I also use the Botox injections, which has been very effective. But if the 50%, 60% patients getting benefit, then we did needed the medications like G-pens and the immunoglobulin to get the help. Triptan, as you saw, that it does help with the vasoconstrictions at that receptor, working at 5-HT, 1B, and 1D. If you remember that these receptors are not selective, they're also in the coronary arteries, so it was a big challenge with the prevention of coronary artery diseases patients that it cannot be used there. So other medications like dietons, they are used also on the same receptor, but they work on the 5-HTB1F receptor, which are more selective, but they don't cause cerebrovascular conditions. So when you see a patient who has migraine, if you see that normally patient has less CGRP receptor there, but during the migraine headache, they have highest level of CGRP. And even if you inject the patient CGRP, they will get migraine only if they have history of migraine. So I'm going to skip those slides because we are running a little bit late. So these are the CGRP medications which are available, and they are subcutaneously injected. G-pens are the CGRP medications which inhibits and bind to the CGRP receptor. It prevents vasodilations rather than vasoconstriction. That's the main useful product which we have it, so that patients with coronary artery disease or other patients, they can be used, although it has to be carefully designed by the physician. The another thing is that, remember we talk about the aura, the cortical spreading. So that's our target also with this medication, that how we can prevent the cortical spreading to reduce the aura and photophobia. G-pens are the remazepan, the erbogipans approved for the acute treatment, and atrazepam is also approved for the prevention. And there are side effects including nausea, vomiting, dizziness, but some of the serious side effects can be seen also as listed here: seizures, pericardial effusion, and spontaneous abortion. So it has to be used carefully. And some of these medications are not available. They are not right now in the formulary. So that's another challenge which we are facing. The monoclonal antibodies are ananemab, targets the CGRP receptor. So they have two things. One is the ligand and one is the receptor. So we are trying to target those things and see how we can get the help with the patient with migraine. So in the patient, in the group where it targets the ligands is the framlizumab, galcanezumab, eptinezumab, I'm sorry, these are very difficult to digest, but inanumab. Inanumab the targets the CGRP receptor. Inanumab and galcanezumab and franizumab, eptinezumab, approved for prevention. Again, very difficult to pronounce and difficult to digest these medications. It causes nausea, constipation. There's another issue with this medication that a lot of the people who have constipation already, they suffer through that. These are all the places where we have opted the detail to present. Now I'm going to present how artificial intelligence can help us in any disease where the patient is coming to our office and how we can structure this and implement in our practice.
Now I want to introduce the exciting changes artificial intelligence will have on the medical and patient care landscape in migraine treatment. This is a revolutionary time for medicine as AI will dramatically increase and synergize the potential for physicians to help more patients with this debilitating disease. AI has the potential to significantly impact migraine care across various aspects. Here are some examples of AI integration in migraine diagnosis, management, and patient support. Diagnostic accuracy and enhancement. AI-based models can improve diagnostic accuracy, especially for non-headache specialists. They can assist in correctly classifying different migraine patient groups and allowing for more structured patient medical history. In effect, we will have history notes congruent to the classification of disease process to allow for qualitatively more accurate history and diagnosis. This medical documentation can be summarized by AI integration after a naturalistic interaction with the patient in real time. Early detection and intervention. AI algorithms can identify subtle changes in patient data, such as sleep disturbances and stress patterns, that may precede a migraine attack, enabling early intervention. Proactive AI alerts will enable physicians to intervene faster in acute migraine evolution. This will enable our patients to start therapy before the migraine cascade evolves. Brain imaging biomarker. Identification. AI algorithms analyzing brain imaging studies, such as MRI or functional MRI, show significant promise in identifying disease biomarkers related to migraines. This is already occurring at a rapid rate in neuroradiology, as the Gestalt theory of learning enables large language models and deep learning to compare thousands of images in real time against the index case to allow for the physicians to augment their diagnostic accuracy. The imaging algorithms are already being incorporated into many hospital systems. Predictive models for migraine attacks. AI can forecast acute events, such as predicting when a migraine headache might occur. This information can guide patients in taking preventive measures. In fact, the predictive modeling is a hallmark of generative AI. Thousands of multimodal inputs can be synthesized by AI and then provide predictive modeling, which was not possible in the past. This will not only improve patient care, but empower the patient. Personalized treatment recommendations. AI can analyze patient data, including medical history, symptoms, and lifestyle, to recommend personalized treatment options based on individual needs. The ability to review all these variables to provide a holistic approach to migraine care is the future of migraine care. Medication optimization. AI can help determine the most effective medications for migraine prevention or acute relief by analyzing patient responses and outcomes. In fact, we are now using patient cell tissue cultures with drug therapy in the lab and biomarker activation to enable physicians to assess which medications will be most effective for the patient in the lab prior to prescribing to our patients. The ability to use cellular data with drug therapy input and biomarker response is an exciting aspect of personalized medication optimization. Therapy response prediction. AI models can predict how a patient will respond to specific treatments, allowing for tailored therapeutic approaches. This approach focuses on AI ability to analyze the various multimodal therapies a patient is taking for their migraine care and allow for optimization of the treatment regimen. Patient headache diaries. AI-powered mobile apps can track headache frequency, severity, triggers, and associated symptoms. These diaries provide valuable data for both patients and clinicians. The AI-powered headache diaries are capable of recording thousands of multimodal data points to better define the headache triggers and the headache evolution, increasing knowledge for medical science and empowering the patient. Lifestyle recommendations. AI can analyze lifestyle factors such as sleep patterns, stress levels, and dietary habits, and suggest personalized lifestyle changes to manage migraines. AI ability to provide a personalized, holistic approach to migraine care, which is not only holistic but congruent to a patient's medical belief system, will democratize their medical care. Telemedicine and remote monitoring. AI-driven telehealth platforms can facilitate remote consultations, monitor patient progress, and provide timely follow-up care. Remote monitoring and consultations will allow specialists to provide oversight in underserved areas and allow specialists, like myself, to support my colleagues outside the urban areas. These applications are still evolving, and ongoing research will refine their effectiveness. As technology advances, AI's role in migraine care will continue to expand, benefiting both patients and healthcare providers. The future is here, and we are at the forefront of the tectonic shift in migraine care with the assistance of AI integration. Thank you. This is Avatar Dr. Nagaria signing out. Now I will turn it back to humanoid Dr. Nagaria. 人工智能正在通过改善患者护理和简化操作来改变医疗领域。我们可以共同创造一个更健康的未来。La inteligencia artificial está transformando el campo médico al mejorar la atención al paciente y optimizar las operaciones. Juntos podemos crear un futuro más saludable. الذكاء الاصطناعي يحول المجال الطبي من خلال تحسين رعاية المرضى. معا يمكننا خلق مستقبل أكثر صحة.
So we can do it it's an hour. I can hour. This was AI, all the 10 slides.